Yes, sir.
Right? Sorry.
I sure do. Sure do. Good morning.
Sorry. Few questions, sorry.
What is a high risk?
Very nice.
Second question.
Yes, sir. So what is a high-risk case for device embolization? It's pretty open-ended, right? Could be a lot of answers to this. So you give your best answer. The biggest mistakes you made, right? Nice.
It may not have come through. If you're not seeing it, there just may be a lag when you have to type in an answer. Yeah. It seems like that's happening, but will happen.
Okay. Spiral defect.
Spiral.
Who said spiral defect?
He's not gonna tell you.
No, just because I like this answer very much. Actually. Raise your hand. You're the smartest guy in the room, at this time at least.
The best answer is number 3. And it happened, I know that.
I know who wrote that answer. Anyway, okay, so there are multiple answers to this.
Okay, next question.
So there's 3 questions.
Oh, just okay. Let's get to the lecture.
This is slide forward and backward, right?
Yes.
All right. Okay. So good morning, and I think 2 fascinating lectures you heard, and now we're going to go to the boring stuff, ASD. But honestly, after doing the ASD closure for 20 years now, I still am baffled by some defects, and there are some defects that I am not able to close. So I was thinking when Eric and the directors asked me to talk about this, what is a complex lesion subset? So, I mean, it's fair to say that the complex ASDs are the ones that we do not understand by imaging or fluoroscopy, or complex ASDs are the ones that we think we understand and then find ourselves in a jam, even the experts. And then we can deal with large ASDs. I mean, that's easy, and we know which ones we should not attempt to close with devices available in our suite. Complex ASDs are the ones that are difficult to close with the currently available devices. If you find a device that can close a defect with very, very short rims, you are going to do it, and they will be no more complex. Complex ASDs are the ones where the left atrium is so small, and this is a complex ASD, that the device tilts or deforms and the discs cannot be made parallel to the atrial septum for deployment. This also means the rims in these type of patients may be deficient. And then complex ASDs are the ones where the risk of device embolization is high, and the complex ASDs are the ones where the risk of tissue trauma, which cause erosion, is higher than in the general ASD closure population. Complex ASDs are the ones that appear complex with intervention because of his or her limited experience. So anyway, in my mind, what is a complex ASD? In my mind, a very large ASD that has more than 2 rims deficiency is a complex ASD. I really couldn't care less about deficient aortic rim. I couldn't care less about deficient posterior rim. I couldn't care less about insufficient AV valve rim. I would care about IVC rim absence, but that will be one rim I'll be very much worried about. I'm worried about eccentric ASD. Sometimes they are located not really in the middle. They may be towards IVC side, maybe too high, maybe two anterior, maybe two posterior. Those are the ones that are difficult to close. Then I'm concerned about ASD that have different diameters in different views. As Mark was alluding to, 3 standard views of 4-chamber, bicable, and short axis. And in bicable, you measure this ASD 25, and in short axis, the ASD is 16 or 17 millimeters. And now it's a conundrum. What size device are you really going to put in this patient, right? So if you balloon size it, even on. So, and then I'm very much worried about this ASDs where the septum is thin, you're almost always going to miss 2 or 3 defects, no matter how good you look at it. No matter how good. Maybe the illumination from the backside that John Carroll showed a beautiful slide, maybe that will be helpful someday in that case. So this is a case I cathed initially for PDA closure, and then it brought this patient back twice and still haven't been able to close it. I offered surgery to them. Mother doesn't want surgery. She's a beautiful young child. So I'll run through this without explaining. This is patient is about 12 kilograms. This is if you look at the pie, that tells you, that pie will tell you if it's a short axis view or a bicable view or a 4-chamber. So 0 to 20 degrees will always be 4-chamber view, right? No matter what you do, unless your transducer or the probe is too deep and or too much superficial, right? So it's 0 degrees, it's a 4-chamber view, so you see all 4 chambers. You see this weird blue flow coming in there. It's not a very large ASD. Okay, here's a bicable view. You still haven't recognized the ASD in this patient. This is a bicable view on the left, 117 degrees. On the right is a 4-chamber view. You still haven't recognized the atrial septal defect in this patient. Now you can start seeing atrial septal defect by pulling on the probe a little bit from the transesophageal probe. On the right side, we have placed a sheath across it. We know this defect measured 16 millimeters, by the way, which is absolutely closable in this patient. We put a cardioform device in this patient. Largest cardioform device in this patient, did not take it off of the thread they have, and about 5 minutes later, it popped out.
So the defect was 16 millimeters
Yes,
by
sir.
2D?
By 2D, yeah.
What was the sizing? Because you can't put the cardioform without the sizing.
You can. I mean,
Well, you can, but the protocol, you need to size.
not
Right,
necessarily. I mean,
right.
you Use
So,
the 30.
so it balloon sizing was about 15, 16 millimeters to make, yeah. And so we went in with the Amplas device. And this device, again, after we waited for about 5 or 6 minutes, popped out very, very easily. So it was very confusing for me what you did. So could you run this faster with me, as I told you? So we did the 3D. So how to deal with this? I mean, I'm not going to put a big device and be happy with it. This patient is going to live next 85, hopefully, years. You know, this is not a 95-year-old patient that you make a mistake, and right? I don't want to deal. If you look at this, this is what somebody said, spiral septum. This is what is spiral septum. If you look inside ASD here, it's like this. So there are 2 rims above, and that keeps a gap in between. And the blue flow that you are seeing is the blood swirling in that area. So now we don't know where the left disc will go, the left side of the spiral septum or the rightward spiral septum. If you put it on the left side, the device remains tilted and it pulls out. If you put it on the right side, the device doesn't stay stable because the rim space is so sharp. So we could not.
So what is this technique here? 3D echo, you said?
This is a remodeling, 3D reconstruction of the. So we did a CT on this patient.
CT. Okay.
Yeah, and then reconstruction with echo. Okay, I didn't do this. I'll tell you who did this for me. Yeah, I didn't do this, but it was a fantastic for me to understand that this was a spiral septum. I could not figure out where I should put this device, and I was happy that at least I didn't put this device. I still have offered this patient surgery, and she still doesn't want to go to surgery. Anyway, so this was a complex ASD for me. So anyway, you heard some beautiful slides. You've seen everything about assessment by imaging. I'm going to, and ICE and everything, so I'm not going to touch on that. I'm going to focus a little bit on transesophageal echo, the simplest way. So this is a complex, this complex atrial septal defect. Now make no mistake, the defect that you're seeing is really not the defect. Defect is higher. Not this. Defect is higher. So LA is almost as big as the disc will be or the ASD will be. You're never going to be able to put the device or the disc parallel in this situation. Even if you think you are able, you can do it. Sometime in the bicable view, when we cannot tell where the IVC rim is, I'll pull the sheath back and I'll take saline contrast and inject. when it comes to the right atrium, it gives you a good vision how long the IVC rim is, okay? And you're not confusing it with the eustachian valve. Okay, it's a very simple thing. It's you to inject 3-4 ml of just saline, and it's really, look on the left side. It tells you exactly where the IVC rim is coming, because this was very confusing. There was a lot of eustachian valve was there, and a lot of things were there. So here you can see again the atrial septal defect. LA is very, very small. You are going to have a really hard time doing this case. You're going to use different maneuvers. You can use different sheets. You can use, but you're going to have. So how to treat with these type of, you can do this case. So I did that case, I could tell you, right? Some small subset may not be closable on this, but you can use left upper pulmonary vein technique in this patient, right upper pulmonary vein technique, atrial roof technique, Dr. Bharat Dalvi's balloon assisted technique, and other techniques. But be mindful of the device edge impingement. It's very important because you're going to put a fairly large device, so be very careful that the device is not impinging, especially on the mitral valve. This is a melanine septum. So melanine septum, the way I described it, I may be wrong, was that if you see the non-coronary cusp, the septum should be almost always in the middle of the non-coronary septum. If it edges towards the left, which 19% of the cases it does, then it becomes malalignment. Now, this is a very easy case to do for all of us, right? There is absolutely no issue in doing this case. This septum is for sure malaligned. And as you can guess, if you put a device in this, the right disc is going to tilt.
Zahid, I'm sorry. Can you point on the picture here? Where is the septum and why do you say it's malaligned?
Yes, sir. Okay.
Show me where is the septum.
Is there a pointer I can use?
There's a pause.
Okay, yeah.
Yeah, because I also don't know.
So this is a non-coronary cusp.
Yes.
Yeah, this is a non-coronary cusp. This is subtle. So that's a non-coronary cusp. Normally the septum should be in this area, right in the middle, by definition that you described. So if it deviates to the left side,
Do you agree, guys, that this is the septum?
Why would you call it? Because
I think the other thing is for sure the eustachian valve.
Yeah. So the septum is weird.
no, that's
No,
the
no.
eustachian
Okay.
valve.
this is eustachian valve.
That's
Yeah.
eustachian
This
valve.
atrial septal
The
defect.
septum is okay, I thought.
Septum is, it's not malaligned to me. I don't know.
It's not. It's not. Okay, let's finish and then we can talk about it.
Yeah,
Yeah.
why don't we say, I would say the questions for the end, we can come back. Just-
Yeah, you should come back to it. Let me finish this. Instead of, let me finish this and then we can come back to it. This is septum that is tilt. It goes this way, doesn't come this way, and you don't see any nub, or what you call the aortic mound in this. Now, as subtle as this finding is, it is really, really important. Okay? We always say, oh, we don't understand this, we don't understand erosion, we don't understand the septum. So we're going to argue about this for a long time. Okay. So as again, here you see, if you see the whole non-coronary cusp, the aortic rim is way on the left side of the non-coronary cusp area. Okay, so this is, in our definition, a mildly malaligned atrial septum. In this 0-degree view, when you push the TE probe a little bit, pull it back a little bit, and the aorta starts coming into view, it looks totally fine. So now how to address this? This is a particular case you really should never ever oversize. Absolutely, this adding 1 millimeter or something is absolutely the most ridiculous thing to do. Because the right atrial disc, even with the slight malalignment, is going to tilt, and the right edge of the right disc is going to push on the aortic thing or the atrial free wall. And ultimately, when the patient goes running and his cardiac output goes from 5 to 15 liters per minute and the aorta expands, you can have significant issue with this. Now, to explain this to you, I want to show you this picture. If you look on the left, this is simulating like you're doing a case in the cath lab, all right? So if you're going to do a case, the sheath is going to come like this, from IVC up in there in the left atrium, and you're going to do atrial septal defect closure. So LA, RA, aorta. Now what you're going to see here is this is the aorta, this is LA free wall. Here becomes the RA free wall, this is the aortic mound. This is the area that separates the atrium. Remember, aorta is never part of the atrium. Separates the atria from the aorta. That's tiny, tiny areas, what you call transverse sinus. right? The second, two sinuses in the heart, right? Oblique sinus and transverse sinus. All right, this is the transverse sinus, most crucial part. Now, if this septum is malaligned, even mildly this way, the device will go like this. So the right disc, there is right disc erosion. Almost 20-30% of the cases have right disc erosion, 70% have left disc. It's counterintuitive, right disc is smaller, why would it erode? Something is happening to those patients, right? So keep in mind this area is where the right disc will continue to pound on the atrial free wall, ultimately will tear the atrial free wall, and if it's big enough or tilting enough, it's ultimately going to the aorta and the patient will tamponade out. So this video should run. And here how you can see the transverse sinus on echo, this is the transverse sinus. All right, that's the aorta. Here is the left atrial free wall, right atrial free wall, and the aortic rim. So always look for this. So we don't pay attention to this. I do. Whenever I look at it, I want to look at it. After doing 2,200 plus ASD, I never had erosion. So either I'm the luckiest man alive or I'm doing something right. It's one of the two. Okay. Okay. And here is a picture. Here is a picture of a patient where the right atrial disc actually has gone into. See, this is the transverse aorta, transverse sinus. This patient is asymptomatic, by the way, but was at that time. The right atrial disc is already in the transverse sinus, so the erosion has already occurred here. But the reason patient is asymptomatic is because it hasn't gone to the aorta, so there is no tamponade. So the small amount of bleeding that occurred caused small amount of effusion and nothing else.
The aorta, why does not cause aortoatrial fistula? Because many of these cases they have fistula rather than tamponade. Why do you say tamponade?
Yeah. So again, I would like to answer it at the end, but to answer your question, as the pericardial reflection where the transverse sinus forms, it comes back up to the aorta. So atria, pericardial reflection goes to the aorta. That's your transverse sinus. If the erosion occurs below the reflection, it will be fistula. If it occurs above, it will be tamponade. So that's anatomically, if you look. So if it occurs at an area where you have a transverse sinus separating the aorta, you'll have a tamponade. If it occurs below, remember the aortic sinuses, where the aortic sinuses are, there is no transverse sinus. So if you're going to hurt it in that area, you're going to have aorta-atrial fistula. If it's above that, you will have pericardial effusion and or tamponade on those things. So here is another way of looking at if you want to look at it. Can you run that if you don't mind, sir? So if you will see now, you can go fast. I hope I'm not on time still. You see here, the device is now, can you stop? That's the transverse sinus. The device is already in the transverse sinus. Hasn't hurt the aorta. So this patient complained of weak chest pain and had small pericardial effusion. It came to me and I said, remove the device. Patient is 27-year-old lady. She didn't want it out. When they took it out, it was a 1 centimeter long atrial perforation. Aorta was totally okay. So just be mindful when you assess complex subset. Keep an eye and keep on these things. Next, sorry, I can do this. So here's example 3. This is a patient. If you can see on the 4-chamber view again on the right and the left. This on the right side. What you see is a transducer slightly clockwise. If you keep going clockwise, you will start seeing the right upper pulmonary vein in these patients. Here's a short axis view. You can see the eustachian valve. Don't confuse that. And here's the atrial septal defect. This is a slam dunk case, no question about it, if you're looking at it now. But when you pay attention to this, you start seeing the coronary sinus. That's your coronary sinus now. When you see the coronary sinus, there is absolutely, positively no coronary sinus rim. It's just a thin membrane-like structure. This case, just like IV serum absence, is a case where the risk, you can do the case, the device will look pristine, but 6 hours later it will go to the right atrium, right ventricle, patient will have PVCs because IV serum is completely absent, the device tilts and goes almost 99% of the time to the right side of the heart. So this is one case I will send them to surgery, believe me. This one case I will send them to surgery. You can do it if you want to. So, right. So now how to treat, avoid closing such device with any device. Risk of device embolization is very high. Risk of arrhythmia, especially AV valve block, increases. Because the lower you are, the anterior you are, the right disc can actually sit on the triangle of Koch area where the AV node is. And surgery in these patients may be the best option. Now, just very quickly going through this, this is simply one of my publication where we define the rims. If when you are doing a 4-chamber view, the angle is this way, right? And this is what you see. You can do very simple thing. You can do 4-chamber, push the transducer slightly deeper. And now what you see here, you should start seeing the coronary sinus. You should start seeing the posterior-most part of the tricuspid valve rim or the AV valve rim and the mitral valve rim. And here you see coronary sinus coming in there, LA almost disappearing, but you're seeing the posterior-most part of the AV valve rim. A lot of time you will see the mitral valve perforation occurred when the guy sends you the picture. The mitral valve, the device was not even close to the mitral valve, then why did the mitral valve perforation occur? Because you didn't interrogate. Mitral valve and the tricuspid valve are fairly long, very, very long. You didn't interrogate from posterior to anterior, but simply pushing the transducer in will give you the coronary sinus rim all the way to the middle, and then you can pull it back. And when you pull back, now pay attention to this, when you pull back, right behind is the aorta. You should start seeing the aorta coming into view, and here you can start seeing the aorta coming into view. So that means you're looking at the anterior-most part of the atrial septum now. So what you have done just by doing this simple maneuver, you have looked at the AV valve from its continuity from the mitral aortic continuity area, not the anatomical thing that I'm talking about, to the backmost part, which is the coronary sinus part of this. Similarly, you can go to 60 degrees, and I want to pay attention because a lot of people said aortic rim deficiency increases the risk of erosion. It's not true. It's not true. I'll tell you in a second why. So you go short axis view, you can do bicaval view, change the angles to 120 degrees. These videos unfortunately won't run, which is okay because I need to explain to you. So when you evaluate the aortic rim, I told you 4-chamber view is 0 to 20. From 20 to 70, 80 degrees is all aortic rim, right? Now, if you have 0 aortic rim at 30 degrees, but you have aortic rim at 50 and 70, 80 degrees, that's not a high-risk case. Absolutely, positively not a high-risk case. So how we evaluate these cases will go to like 19, 20 degrees, 30, 40 degrees, 45, 50 degrees. You can see you're looking at the aortic rim in all these. This is the aortic rim, this is the aortic rim. Suddenly, this was very small amount, this is a very small amount. Here is a decent size aortic rim. You go to 60 degrees, you may not see it at all. You make a 70 degree, you may not see it at all. You go to 80 degrees, which is the realm of going into the bicaval view, and you finally go to bicaval view. You can do that in about 2 to 3 minutes, really. But you have interrogated now the whole atrial septal rim from 4-chamber view, short axis view, and the bicaval view. Okay? Now, this is actually a slide from John Carroll, long time ago. I don't think even if he remembers it. But I don't know what he used it. He does? Okay. Good. Well, so I want to show you, if this is the aorta, why this, if you do scan this way in short axis view, you will say the patient has 0 aortic rim, right? There is absent, aortic rim is absent. Is this a high-risk case? Absolutely no. But if this was an oval defect, where these dotted lines are, and it becomes like this, and you go 20 degrees and you have no rim, 30 degrees you have no rim, 40 degrees you have no rim, 60, 70 you have no rim. Now you're talking about a high-risk case. Then you can say this is a high-risk case for erosion. But if it's only 20 or 30 degrees, 1 or 2 areas where it's deficient or even absent, it doesn't make it a high-risk case. So scan the aortic rim completely. Just don't go to 50 degrees, look at it, and just rule out that this case is doable or not. Okay, so this is my conclusion. Complex ASDs have several rims deficiencies, multiple angle aortic rim deficiency, coronary sinus rim absence, IVS rim absence. They have anatomy that is difficult to understand by imaging. Imaging, though remains, even though is still the cornerstone for successful assessment and closure. With the future, as you saw some amazing talks before mine, 3D printing, MRI, CT may be helpful. I think they are going to improve your specificity, things you probably should not do, but they are not going to help you in closing them. You still have to know how to do it. Thank you very much.
Zoid, thank you very much. Zoid, just one before you end. I don't think there'll be any time for questions. We're way over time. But when you said you want to scan the anterior aortic septum, by changing the angle, the other way is just pulling the probe back and forth down. You can still see the aortic rim. You keep the same angle of 45, and you just retract the T probe you'll see some of the aortic rim higher up.
You
You don't
won't
have
see
to
it
change the
completely.
angle.
You won't see it completely.
Yeah.
Absolutely no.
I agree,
Yeah,
yeah.
I completely disagree with that.
I would just say that, so all of the videos and all the lectures, this is a very detailed and
Intense.
very heavy, okay? Like your brains are wrapped around the 3D. It's heavy, this stuff. It's like, you know, even if you think you understand the heart, it's heavy. All the videos, all the lectures will be on the website within the next couple of weeks, as soon as we can just cut them down. Yeah. So you'll be able to just go and kind of review this.
Yeah.
Review this if you want. Add to that. Yeah.
Shall we
Eric,
do
we're way
the
over
questions?
Yeah, sure.
Yeah, let's do the
Let's do the
questions and then we'll.
Yes, sir.
One of the big advantages of T versus ICE is 3D capability.
Yeah.
What's your experience with just doing 3D for an assessment for ASD closure, no balloon sizing? You will still with 3D imaging and decide the device.
With ICE 3D or with
No, no,
transesophageal?
With tests for the T 3D.
You know, I must tell you that 3D TE so far scares me. When I look at the ASD in 3D TE, I really don't understand it very well. I probably feel it better when I do with 3D ICE, actually, than 3D TE. I think two-dimensional, maybe because we are older and we are just so used to two-dimensional. I think for you guys, understanding 3D, sometimes 3D actually scares me with the septum moving too much and stuff. But I think if you do understand it, I think that's the way to go.